Hello, everybody, and welcome to another HRN Live, or the Lung Talk Show. Lung Talk Show. I'm your host, Alexander Gritchuan. I'm the Director for Advanced Lung and Heart Disease. And today's topics, I'm going to talk a little about the 25-minute bike with the class I had last week, and as well as seeing you at your best versus your worst. So, as I go over this topic right now, it's like hey, Jordan? Can everyone hear me and see me okay? Everyone give me a thumb, or just give me something here. Hey, Jordan? You are able to, okay. And you guys are able to see me and everything? All right. Just want to make sure, don't want to do anything that you guys can't see or hear me. All right. So last week we talked a little about, we had some topics up, but this week, I'm sorry, I'm mixing up my words here. Last week I did a 25-minute bike. And when I start this exercise up with my class, and as well as keeping it going and stuff like that, this is where the times I usually see the most problems. At 20, when somebody's trying to get to 25 minutes, I'll see a lot of my patients stopping before that or continuing and just finishing out 25 minutes. All in all, my class fulfilled the 25 minutes there, but I did see about 3 people that had some problems. And the problems that I usually see are oxygen dropping, work of breathing is higher than what they felt. Somebody's endurance is not up to a good level yet. This is where I tend to see a lot of the problems. And when I see problems, that's where I come in and start fixing those problems. So that goes on to our next subject, or our next topic, which is, I'm trying to make this making this as simple as possible for everyone to understand. When a clinician sees you only at your best, they're never seeing you at your worst, right? Of course. So when somebody comes into therapy and they're saying they have, I had an exacerbation, 6 months ago, or I had this problem, and even if it's been a while, but they're never coming into the program at their worst sometimes. What I'm trying to say is clinicians can be blindsided by the responses from each and every individual. What I'm talking about are patients. If the clinician is only seeing you at your best, they're not seeing you at your worst, right? They're not seeing that you have, during your exacerbation, you have a heightening of this, you had more wheezing than normal, you had more congestion. Everybody's symptoms are different, okay? When somebody talks about, all right, I have this lung disease, it causes me to wheeze uncontrollably. Okay, that could be asthma, right? It could also be acute bronchoconstriction. It could also be a lot of other things. It could be a new medication. We don't know until we see it. When you go into your doctor's office at 100%, where you're not having any problems, they're going to think you're okay, right? But then you try to discuss with your doctor or your clinician about, hey, when I walk, I have this problem. When there's a lot of pollen, I have this problem. I have, I don't want to say you have a heightened IgE response, immunoglobulin support system. What I'm just trying to say is that you're trying to relay information to your doctor, but your doctor might not be seeing this problem that you're having. So the best thing you could ever do is when you're going into your doctor's office or you're coming into the program itself, seeing you at your worst is sometimes the best thing you could do. Because if we see the problem, we have to react to it. If a doctor's seeing your problem, they have to react to it, or else it's considered neglect and you'll get worse in overall time. But if you come in to your doctor at 100%, or you're seeing your clinician always at 100%, they're not going to see these problems. You're relaying these problems, sure, but they're not seeing these problems. They don't know, and probably you don't know, that you have more sensitivity to certain environmental pollution. Okay, so being around wildfires, being around a lot of pollen, being around dry areas versus humidified areas. Everybody's a little different. So coming into your doctor's office or coming into a program where you're always 100% and you're not having any problems is not really the ideal thing you could ever do. You want to come in even when you're not feeling well. That's what I'm trying to say is you always want to make sure you come into class, as instructed by your clinician, as you're doing pulmonary and cardiac rehabilitation, but specifically pulmonary, as that's what I work on, is specifically pulmonary. I work on cardiac and pulmonary, but 95% of the time it's more pulmonary than anything. So as we dive kind of deeper into this for looking at problems, if somebody is working out with me and they're only working out for about a minute, or two, and they just stop because they didn't have enough gas to keep going, though that will relay a different problem, right? If somebody is walking, let's say on a treadmill at 1 mile per hour, and they're walking very slowly, they might be good at that pace. But as soon as they start speeding up, going to 2 miles per hour, 3, 4, 5, 6 miles per hour, that's where they have more difficulty, and they'll try to avoid those high intense areas, of exercise because it causes them a lot of problems. I understand that completely. But if I have a patient that's only walking X amount of distance, X amount of feet on distance, because they get so short of breath, or maybe their oxygen goes down, or maybe something else happens, that's where we want to strive the most. We want to strive on the problems that we have, not necessarily on what we can do. If somebody can walk very slow, and that's all they ever do. I see this all the time in the gym. Somebody goes into the gym, they're like, Alex, I go to the gym every single day for 30 minutes. I work out on my treadmill, but I'm not increasing my volumes. I'm not increasing anything. Well, that's obvious because first off, if you're trying to increase lung volumes, a treadmill is not the type of machine that will do that. Because you're just using what your body has, to breathe. So that's not what really is going to help with that. It might help with endurance, yes. Maybe some strength training a little bit if you have an incline. But if somebody can only tolerate 1 mile per hour, then that's all they can tolerate. As soon as they start going faster or trying to go uphill or going upstairs, it might take more out of them. So we don't want to work our patients out only on what they can do. We want to try to get them to work out a little bit more than what they couldn't do before without overdoing it on them. Does that make sense, guys? Does that make sense, everybody? When somebody's working out with us, we want them to not just try their best, but they want to keep continuing. In my class, I only had 3. I had nearly every single person in that class satisfy 25 minutes on their bike. And they did very, very well, very, very well. I saw 3 people that their oxygen dropped a little bit too much, so I confirmed it with another finger with their pulse oximetry. So when they put it on their right hand, I told them to put it on their left just to confirm that the numbers are valid. And so some of the numbers that I was looking at, everyone did fantastic, but there was 3 people I saw that need a little bit more work with their volumes. When somebody's breathing during an exercise and we see oxygen is dropping too much, then we're thinking volume might be the culprit. Investigating these things is what makes the program so fantastic. Because if somebody is trying to work out at 7 to 11 miles per hour on a bike, which isn't actually that incredibly fast, it's actually moving at this pace. That's how fast the wheels are moving, or the pedaling is moving. Okay? It's not moving incredibly fast. But if somebody can't tolerate for a minute or 2 minutes, when we work out with people, we base it off of their maximum heart rate criteria and, of course, any recommendations from their doctors. And that's what we do. We work out within their limits, but there has to be times in the program where we have to pull them out of their comfort zones just for a little bit. We have to, all right, you're going 2 miles an hour, let's go up to about 3 to 4 miles per hour, or let's do this, let's do that. We need to pull people out of their comfort zones, because walking at 1 mile per hour might be okay for you because that's what you're used to doing. You just don't like those higher intensity levels that gain the best results, the best outcomes. And that's what you want as a patient. You want to be able to do more. You want to be able to do more. You want to be able not just to what you currently can do, but what you could potentially do, right? All right, there's a question from Michelle. I have a great question. When you have a flare-up, should you not exercise or just rest? It's a great question, Michelle. When you have a flare-up, when you're on medications that, like for an infection, you have a flare-up, anything like that, not just because you're on medications as routine maintenance medications. I'm talking about medications that help fight an infection. It's a good idea to get a recommendation from your doctor on what you should or should not do as far as exercise. But from what I've seen, anybody who's on a sophisticated type of regimen of medications and they're working out, they tend not to do very well during exercises because they might have a temperature. So we don't allow those people to work out with us, and the only reason is it's a temporary hold. We're waiting for this medication and for this infection to be done with, right? And the reason behind that is when you're sick, you should not be working out as aggressive. You should be resting as much as possible to gain your health back. So to answer that question, you should rest, but I would absolutely talk to your doctor just by calling. Just calling your doctor and say, hey, doc, or maybe it was a nurse practitioner or a physician assistant who rendered care to you. But I would just mention, how much exercise can I do with the medications I'm on, or should I rest? Something as simple as that. Just by relaying that information, if your doctor or healthcare provider has there's no contraindications, all right, you're about a week into your medication, you can start working out, versus you're very sick, you're on medications, I don't recommend you working out until next week. Take the recommendations from your healthcare provider, because they're the ones who actually have you as your patient. We have you as a patient, but working with your clinician, with your healthcare provider, to gain your independence back. And that's what we do at HRN, is we do that. We work very closely with your healthcare providers to be able to do that specifically. Any questions on with that? You're very welcome. You missed me? Well, I'm still in the program. I'm still working everything out. Yeah. There has been, there's a lot of news out there, especially with COPD, and new types of treatments and advances in COPD itself, or lung disease in general, and that's including obstructive with restrictive lung disease. So it's not just COPD, but it's also IPF, fibrosis, things of that nature. And one question I get a lot now is about stem cells. There's not enough information yet. There's not enough information. If information is accruing and it seems that there's a high benefit, not just off of 1 or 2 people. You take 100 people and only one of them or 2 of them out of the 100 got better off of that, it's not a good outcome. You want at least more than 30% recovery off of a certain procedure or certain medication to be deemed as that being successful. Okay? And when somebody takes a new medication, a lot of times some people are thinking they're going to get 100% relief, and that's not true with any medication. You do get relief, but it's not 100% relief, So let's say you took a medication like albuterol to decrease wheezing. You should never be expecting 100% relief. So that does mean after you take those medications, you could still have a little minor wheezing afterwards, but still that medication worked. So understanding that, and by just simply educating yourself with new medications to new procedures, if there's not a lot of good data, I can't be pro with that. Okay, I can't be pro towards it. So I can't say that, all right, stem cells is the answer. I can't, because the information out there isn't enough for it to be deemed as reproducible. That's the best thing I could say, actually. If it's reproducible where it's more than just 1 or 2 people out of 100 people that are benefiting from this and this works, then I could see, okay, if it's more than 2, let's say if it's more than, it's 50%, it's 30% or greater, then I could see, all right, that's being more reproducible. So I'm getting better outcomes out of the 100 people I'm testing this certain procedure on. Big pharma companies do the same thing. When they make a new medication, they have to show peer review that this medication works, and it doesn't work just on 1 or 2 people. Because if it does, then the criteria for this type of medication will only be applicable to certain individuals. Does that make sense? Does everyone understand? I hope I'm not making it too complicated. ABCs of medications and Apple for wheezing. Yes. Yes. Yeah. For those that don't know, you can decrease wheezing by 30% by just eating an apple, and it also includes with the peel of the apple, which we did find it being one of the largest reasons for the reduction in wheezing is the peel of the apple. But in case you didn't know that. Any topics anybody wants me to go over? Michelle, do you have any topics? Anybody else? Karen, anybody has any topics you want me to discuss today? I can discuss any types of topics, but in our Pulmonary Rehab program, I have some spots available for anybody who's interested in being in the rehab program. Remember, it is through HR and it is remote. We'd get a ton of patients in for this remote program, but I do have some more availability under my belt for anybody who wants to try the program out or is interested in being in the program itself. That's a good question. Michelle wrote, the dangers of buying oxygen online. Oxygen is, here, let me see if I know I shouldn't be coming off set, but let me grab an oxygen bottle right here. Okay, this right here is an E-cylinder. Okay. Now, this E-cylinder, whether you like it or not, is a missile. It literally is a missile. What I mean by that is if I knock out the top regulator by dropping this, this will act as a missile and it will shoot very fast. I've actually seen this firsthand. Actually, it did happen with an H-cylinder. It's a G-cylinder. G-cylinder, very large tank. G-cylinder, I did see it with an E-cylinder firsthand where the control valve got knocked out and went through a few walls and outside the building. It ended up in a field, if I recall. It ended up in a field, but yeah, if there was anybody in the way of this, it'll go right through them. No doubt about it. The PSI, the pressure per square inch, goes about 2,500 PSI inside this tank. Now, as far as oxygen goes, compressed oxygen, the FiO2 on this, on pure oxygen, is going to be pure. So meaning that it's not going to be 70% oxygen with other, 30% inerts. This is pure oxygen. Okay, concentrators are not pure oxygen. It concentrates it, but concentrators only concentrate it up to around it's like around 93-95% fraction of inspired oxygen. So it's not quite 100% on concentrators. But what happens if I breathe in too much oxygen? Let's say I bought some oxygen online. What if I breathe in too much oxygen? Well, people don't realize oxygen is a medication. It's a medication. It's always a medication. These other oxygen bottles that you can buy online, like Boost, if I recall, Boost, and there's another one. Those are not 100% oxygen, by the way. They're not 100%. Okay? They're about 95%, but they're also, on the bottle itself, it says, actually, I think I actually have one. Let me grab one really quick for you guys. The oxygen bottle, I know you guys can still hear me. I'm just going to see if I can grab one, if I have one. I'm sure I do. Yeah, I do. If I breathe in too much oxygen, I could actually lower my heart rate down, which might seem okay for some people, but you're forgetting why is your heart rate increasing. So there's Boost right here. Okay, do not puncture or incinerate container. Do not expose to heat or store at temperatures above 120. Now let me look on the back of it and take a look at this. I'm going to read it verbatim. This is from the Boost Oxygen Company. These statements have not been evaluated by the Food and Drug Administration. So this has not been evaluated by the FDA. This product is not intended to treat, to diagnose, treat, or cure, or prevent any disease for recreational purposes only. Boost is filled with aviators breathing oxygen, ABO, and not medical oxygen. This is not a product for medical or prescription use. So they have to put that on this because this right here, this Boost Oxygen, let me see if I can show you the air quality. There we go. Is 95% pure oxygen. That's it right there. 95% pure. Okay. What is the oxygen that we breathe in the room right now? What's the percentage? 21%. So room air, you breathe 21%. And you're bringing in 95% pure oxygen to somebody who, let's say, has lung disease. And their biggest problem is not the oxygen, it's the CO2 because they're chronically obstructed. Okay, that means CO2 has a hard time coming out. So just imagine you're slowing your heart rate down, and your heart is to pump blood that holds oxygen and CO2. Okay, so if you're slowing your heart rate down, and even if you're breathing super fast, that CO2 is not being readily pushed around your body fast enough to your lungs so you can breathe out that CO2. So if you slow your heart rate down, you are inadvertently going to increase your CO2 and you might actually pass out, if not worse than that. Okay? So when you're buying oxygen, you should only buy it from where? Something that's at least approved to the FDA, first off. Okay, proof to the FDA, but what else? Like, I have no problem with buying this if I was a diver, which I am a diver. I wouldn't have a problem with buying this for emergency use, but non-medical grade. You know, for like, let's say somebody was freestyle diving and they held their breath too long and they passed out. Sure, I could use that. Sure, I can. Of course, CO2 is very high. Somebody's holding their breath for, I'm talking about like 20 minutes, 15, 20 minutes. And there are people that can do that. They're called freestyle divers. And they train their body to be able to hold their breath for that long of a time. Some magicians, if I recall David Blaine, I recall, he breathed in pure oxygen, lowered his heart rate and barely moved, and he was able to hold his breath for a very long time. What causes out of breath, guys? What causes out of breath? CO2. It's not the oxygen. CO2. Okay? But when you're bringing in pure oxygen, you get a euphoria. It's almost like, I don't want to say high, but you're getting an oxygen high in a sense. You're having this euphoria of feeling much greater, but you don't realize you're going to start seeing stars in front of your eyes. You're going to start passing out because your heart rate is going too slow. It was beating at 80 beats per minute. Now it's dropping down to 70, now to 60, now to 30. And of course, our heart stops when it hits around 40 beats per minute. It's not a good thing. When oxygen drops down too far, it does cause quite a bit of problems there. How do you know if you should see a cardiologist or pulmonologist for my breathing? Well, that's a good question. The only way to really check, Karen, is to actually go to your doctor. It could be your cardiologist or pulmonologist and ask, hey, I need to get checked out. I have an increased work of breathing, and atrial fibrillation is a direct contributor to increased work of breathing. But we just have to understand what is the heart. The heart is a pump. That's all it is. It's a pump. It pumps blood 5 to 8 liters per minute throughout your body. It's a pump. Its job is to pump nutrients from one side to the other side, and that's what it's for. The lungs are made to bring in oxygen, get rid of CO2, made for breathing. So if we're breathing but our heart's not working, of course, we're not going to work out, right? So who's best to see? I'll just any of them, really. Pulmonologist or cardiologist discuss. If you go to your cardiologist and they find that it's more pulmonary related, then you go to your pulmonologist and they'll just say, hey, I think your pulmonologist needs to know this, or we both need to work with you. Because now you have maybe a lung disease and a heart disease. So who to go with first? As long as it's a doctor and it's your doctor, I would say pulmonologist first, but that's just me. But there's nothing wrong with going to your cardiologist. All right, best exercise to increase lung volumes and improve DLCO. To improve your DLCO, the DLCO is the transimpermeum membrane on the alveolar capillary walls that allows gases to transport past those membranes. So everybody has them, but we look at the DLCO, the higher the number, the better. The lower the number, the worse it is. Meaning if it's a low number, that means gases are having a hard time transporting past each other, and somebody might need to be on higher oxygen, or we need to increase their lung volumes to increase the density, we need to basically stretch out the lungs to thin out the membranes to allow gases to transport past those. So the only way to really do that is through a numerous amount of exercises, but the main exercises, my go-tos, are hyperinflation therapy and respiratory muscle training. That's what I use specifically to increase DLCO scores. Okay, respiratory muscle training, and that's done 6 times a day, 10 minutes each, until we get the optimal result that we want. We get the result we want out of that. Let's see, Michelle, without a prescription. Yeah, people should not be buying supplemental oxygen by themselves. They should be going, because if it's any oxygen that you're buying, I promise you it won't be prescription-based. Because if it is prescription-based, because oxygen is a medication, for those that do not know. It's a medication. Room air oxygen is not a higher percentage. It's a 21%, so that's completely legal. You need a prescription to breathe air, but to breathe more oxygen, because too much oxygen will do what? Kill you. It can kill you. Too much oxygen. Going into a room of pure oxygen, you're not going to feel great. Your lungs are going to start to collapse. There's a lot of things that we look at in the clinical field before we put somebody in a pure oxygen chamber, but there are reasons why we would do that. But that's for healthcare providers to do, as they provide health care to each individual. Any other questions in regards to that? Any questions? Guys can bring up any types of questions. Anybody like see the eclipse yesterday? I think around 2 o'clock I saw. It was a little after 2 p.m. in Owings Mills, Maryland, where we're at. But we got some pretty good sights of the. Hi, Rita. Hi, everybody. In case I didn't say that, I thought I did. But we got quite a bit of. Yeah, we had. It was like 85% blackout. It was 85%. Did anybody enjoy that? Anybody see that? Did anybody notice the temperature dropped by 2 degrees when that happened? If you saw it, it was some locations were even more. But when the sun was blocked out, it didn't radiate a lot of heat, of course, and the temperature throughout the world actually dropped by a couple degrees, and that's common, of course, because that's what happens when you block out the sun. But did you ever know? Did you see that? Did you find that? Did anybody find it interesting? Take a lot of pictures. So you should never be looking at it, directly, but looking at it and using different types of filters or different things to see it. Anyways, it was a pretty nice sight to see. it was kind of scary a little bit. I think some people were scared of it, but yeah, the environment around you was very eerie looking because it was getting darker, even though it was afternoon. All right, Shelley, here's a question. With severe COVID fibrosis and, fibrothorax from the ICU, hemothorax, how is weight able, How is weight able to help low DLCO and volume? Is it significant? Well, with fibrotic changes in your lungs start solidifying, Shelley. And when they solidify, there is no medication to fix that. It's an actual therapy you would do. And what I mean by therapy, it's an exercise that we don't necessarily would show somebody, we would do it with them. I'm talking about like, once I set something up with somebody, like respiratory muscle training, I got to make sure they do it right, or else they're going to keep doing it wrong, if they're doing it wrong. So when I take a patient, I see a patient having this problem, there is no medication for it. It's specifically lung stretches, respiratory muscle training, volume exercises, that reverses that. Okay, it doesn't cure it, it reverses the problem, and we don't have that problem as bad as we used to. That's what we do. So from COVID fibrosis, yes, long-term COVID, or another way of saying that your lungs are solidifying as fibrotic lungs. Yes, that does tend to be a big problem with COVID, people that are suffering through COVID, but pulmonary rehab would be your first go-to. It should be your first go-to. You saw, Rita, how funny it was, how it got cold so quickly? Yeah. Yeah, I saw that. I looked at my temperature gauge, it was like 77, and then went out to 70 degrees. But I think on average it was like a 2% decrease in temperature. You took some pictures, Brenda? Fantastic. Let's see, Michelle. Bluing lips and fingertips is a medical emergency. Can we go over this? Yes. Yes. So, bluing of the lips or bluing of the fingertips, first let's look at temperatures. If the temperatures are very low throughout the whole body, where you're hypothermic, it will cause irregularities within the body and the chemistry within the body as far as oxygen absorption and release of oxygen into certain tissues. So is it an emergency? If I see bluing of the lips and bluing fingernails, yes, definitely an emergency, because there's cyanotic. There's somebody who's suffering through cyanosis, where they have lower oxygen amounts. Not hypercapnia, which is a heightening of CO2, but the oxygen levels are very low on those limbs. So when somebody has low oxygen, the first places to go blue, where you see most of the symptoms is the lips, gums, nose, fingernails, earlobes, fingers, toes. Those are usually the first ones to go. Just like if you go into water, cold water, and you're in cold water for a long time, and the temperature is very radically low. And when you come out of that after being in there submerged for maybe about 2 minutes, you tend to see somebody with bluish lips, bluish gums, nose, ears, fingers, toes are all very, little lighter in color, meaning they're a little bluish, and that's cyanosis. So how do we fix that problem? Well, first off, if it is a temperature problem, we have to fix the temperature. That's your first go-to. Second, if it's low oxygen, and we just have to understand that when we put a pulse ox on, that's the last site where oxygen travels to before blood circulates back to that area, because there's no other place to go to. When it goes here, it circulates back. When it goes here, it circulates back. There's no other place it goes to. Okay, so at the very last line of sight on an extremity, like if I have bluish hands, fingernails, and I put a pulse ox, it's going to read very low, right? But the first thing I want to do is it reading low because I have low oxygen, or is it read low because I have low temperature? That's the first thing I want to look at. If my hands are very cold, let's just say if they're cold, no matter what, the readings are going to be erroneous in reading. It's going to be an error reading. All right. So if it shows 30%, obviously that can't be correct, because you'd be dead if that oxygen level was correct. If you're setting at a 30%, your heart stops at 40. And the fact that you're still alive and you're seeing that is because your fingers are very blue because of maybe temperature. But if it's an actual emergency, first thing you want to do is go to the doctor. You want to go to the emergency room if you're seeing that, and there's no other reason for it. You don't have cold hands, you haven't been submerged into freakishly cold water, then you want to go to your doctor and see what's going on, because delaying this could actually result in more worsening of symptoms. All right. Tammy, does the tank oxygen or the portable inogen pulsating better to go out and help breathe through a long day? I don't feel my inogen is giving me enough ongoing oxygen, but I haven't used the tanks. I do become shortness of breath when using the portable. Again, Tammy, let's go back. Oxygen doesn't cause the work of breathing. Oxygen doesn't cause the increased work of breathing. Guys, this is basic knowledge. So let's look like this. Tammy, you're using oxygen, and you're wondering. So according to what you said, does the tank oxygen or the portable inogen pulsating better to go out and help breathe through a long day? I don't feel my inogen is giving me enough ongoing oxygen, but haven't used the tanks. I do become shortness of breath. The shortness of breath isn't caused by oxygen. It's caused by CO2. So you might be bleeding in a lot of oxygen, but what does a lot of oxygen do? It also will slow your heart rate down. Some cardiologists will give you oxygen just to slow your heart rate down. Okay? Why are you becoming more short of breath? How about this, guys? How about this? Let's pretend I cut myself, okay, on the wrist, and I'm bleeding profusely. In fact, I'm bleeding so much that I'm probably going to die from low blood pressure, okay, because I've been bleeding out. I'm hemorrhaging. I'm bleeding out. What are the symptoms of bleeding out? What are the symptoms? Can anybody relay any symptoms of bleeding out? When somebody's bleeding out, their blood is leaving their body, and I'm talking about a large quantity. What are the symptoms? Can anybody put in any information on the comment section? You are breathing super fast when you're when you are removed, when there's a lot of blood coming out from your body. That's one of the symptoms. You are bleeding super. I mean, you're bleeding a lot, but your work of breathing is what I'm trying to say. Your work of breathing is going to be well above in the 20s if 10 was the worst. I mean, it is going to be super, super high, your work of breathing. And that's because there's not enough what? There's not enough blood in your system to carry CO2. There's not enough oxygen to push it throughout the body because you're bleeding out. Your blood is holding all the content of the CO2 and oxygen, and you're bleeding all this out. If CO2 is being readily produced all the time, which it is, that means we have to have a respiratory rate of anything that's above 12, less than 20 breaths per minute. So that means we have to continuously breathe. Okay? If you're stating why you're getting more work of breathing because you're wondering if your inogen is not working, maybe it's working very well because it's bringing in so much oxygen that there's not enough space. Look, let's say I put oxygen, okay, and this is a red blood cell. And I put oxygen, oxygen, oxygen. I fill up this area on this red blood cell with all oxygen. Where is the space I need to put on CO2? Where's the space for the carboxyhemoglobin? Okay, for CO2. Where do I have room on this red blood cell to put CO2 in? There isn't. Because you have nothing but pure oxygen coming in. You have no CO2 that can land onto this red blood cell because you brought in too much oxygen. So why are you having an increased work of breathing? Because your blood cells are holding only oxygen, and they're not holding any CO2 to relieve the body from CO2. So you're having an increased work of breathing because you're breathing in too much oxygen. Do you see where the problem's at? The problem is because you're bleeding in too much oxygen. It's causing a heightening of your work of breathing because there's not enough space on your red blood cells that carry your hemoglobin. Your red blood cells carry oxygen and transport CO2. There's not enough space on there. Think of it as a four-passenger vehicle. Good thing I should be in a dolly. Imagine you have a car, and it can only carry 4 people. Okay? All the passengers, including the driver, is oxygen. And then you have CO2 that's coming in. Where can I sit? And you're like, well, maybe in the trunk. Or the trunk's filled because everybody, baggage, all the oxygen baggage is all in there, so there's no room. Okay, what I'm trying to say is red blood cell is like a truck. It's like a vehicle. And it's literally, that's what it is. Its job is to transport nutrients from point A to point B. If there's not enough space in that vehicle, then the CO2 stays in the system. It has to wait for another truck or another vehicle that might have some space for it. Because you can't just pile up a gallon of CO2 onto one red blood cell. It will never work that way. CO2 is what causes out of breath. So if you're trying to decrease work of breathing by increasing oxygen, you're going to pass out every time, or you're going to come close, or you're not going to be able to do a lot. How come me increasing oxygen is not decreasing my work of breathing? Because oxygen doesn't cause out of breath. It doesn't decrease work of breathing. It never has. This is not something I'm stating. This is something that in the medical journals, it's written everywhere. This is nothing new. I mentioned this like millions of times. But for some reason, I don't know how we're not understanding that. You don't increase oxygen to decrease work of breathing. You know, you increase oxygen when somebody's oxygen is dropping. Not when, when somebody's oxygen is dropping and their DLCO is very, very low, you increase their oxygen. If they're having heart complications where they have atrial fibrillation, they might be on oxygen because of that. Okay? I think we're thinking lungs are only supposed to bring in oxygen, and I'm only supposed to be breathing only oxygen. That is not near the vicinity of correct. This should not be news to us, everybody. You need pulmonary rehab. That's it. That's the go-to. There's no special medication. There's no medication to fix stiff lungs. Nothing like that. The first symptom of bleeding out is not the color. That's the worst symptom. That's like the last symptom. Okay? When somebody's getting sick, what's the first symptom of getting sick? Fever, usually. Then it comes to the sore throat. You get a small grade fever, low grade, very low grade. Then it's getting worse as it goes overall, as it gets more and more mature. And it becomes more of a nuisance, to your body. But you don't call the doctor when you're near death and you're blue in the face. You call your doctor when you first see the first symptom. You never call your doctor at the very last minute where you're basically knocking on death's door. You don't ever do that. Guys, this should be, it's always step one. Contact your healthcare provider anytime you see something out of the ordinary. It could be a low-grade fever. Even if you don't feel like it's necessary to call your doctor, still contact your doctor. Just let your doctor know. Who's the dude sitting next to you with sunglasses? Yes, Karen, this is my tracheostomy guy. I call him Bob. Don't know why I call him Bob. I think there was something in a long time ago, and we just called him Bob. But this is Bob, where I teach a lot of trach care and sometimes chest physiotherapy and stuff like that. So I kind of use them as I should. That's what it's made for. But Tammy, do you understand that? I know it's not everyone's go-to because everyone's like, oh, I don't want to do pulmonary rehab because I have to move, I have to exercise. But that's what you should be doing. It's not, eating healthy. Yes, that's what we should be doing. But is there a lot of junk food in the world? Yes, but that's what I want. I want the junk food, but I don't want the healthy stuff. I want this, but I don't want that. Sometimes, and most often, that we want to do something that's better for our body than what's not good for our body. My body right now is craving nicotine, let's say. But is it good for you? Of course not. Just because you want it, your body likes it, doesn't mean it's good for you. Because in the long run, it's going to hurt you quite a bit. Why the sunglasses? Jordan did that. I did not put these sunglasses on, Bob. I think because it was actually the making of this mannequin came off a face of an actual cadaver, and I think some people find him very creepy, even though he's just educational. And they put the sunglasses. Plus, it makes him look kind of cool, you know? All right. My sats drop pretty low when I am walking, which causes me to be short of breath. Your oxygen, Catherine, doesn't cause you out of breath. Guys, come on, please. Please, understand this. Work of breathing isn't caused by low oxygen. We're looking at our oxygen, but you might not be looking at your heart rate. You got to look at your heart rate. You got to look at your heart rate, you know. But oxygen drops because of our body needs it. CO2 is produced from the organs that need to, when it absorbs oxygen, CO2 is built up and it's released from lactic acid. I know VO2? Catherine, you mean CO2? But if your oxygen is dropping, make sure we're understanding that heart rate, your heart rate. You want to look at your heart rate. You know, the higher the heart rate, the higher the CO2 content usually. You know. Let's see. Yes, thanks. Just thought continuous pure oxygen tank oxygen might help. Graduation day is a big day. Oh, absolutely, Tammy. Absolutely. But should I bring up the material? Maybe I need to bring up this material. Let me see if I can grab this, because it tends to be a very common topic, but maybe people are not realizing that as a licensed medical practitioner, maybe you're not realizing I base everything off of facts. This is a book that respiratory therapists use to ascertain all the knowledge in here, and then they have to go through the clinicals, but they use this to graduate. They need this information in their head to be absorbed. So I'm going to, if you guys bring up Catherine, heart rate, yes, you always want to look at heart rate. And I want to mention this really quick. See what this is right here? That's Holden Knack. I'm not sure if that guy is still alive. But when I was in college, I studied at night because I worked 3 jobs, and that's just what I had to do. But at night, I worked 3 jobs. My time to study was about 4 hours, and then I had to give up a lot of sleep to do it. But I worked at a facility for people with Down syndrome, people that are very disabled, and they're very dependent on other people. And this gentleman here couldn't talk. He was not able to talk. You know, I looked at each and every one of those people with Down syndrome, with people that, and these are fantastic guys and women. They're just fantastic. The greatest personalities you could ever possibly imagine. You know, everybody has their own problems, but I told them, sign your name on this, because every time when I open this up, first thing I see is a signature, and he kind of gives me that boost to always keep studying, keep going. But what I'm trying to find right now is I need to find this so I can kind of show you exactly on oxygen. Okay, let's see, ventilation, work of breathing 226. There we go. Work of breathing. Okay, I'm going to read this out. Okay, it's not going to be a long read. I'm not going to read the whole book. I'm just going to read a little bit. Work of breathing. The respiratory muscles do the work of breathing. This work requires energy to overcome the elastic and frictional forces opposing inflation. Assessment of mechanical work involves measurement of physical parameters of force and distance as they relate to moving air in and out of the lungs. Assessment of metabolic work involves measuring of oxygen cost of breathing. Remember what it says. Assessment of metabolic work involves measurement of the oxygen cost of breathing. I'm reading it verbatim. During normal, quiet breathing, inhalation is active and exhalation is passive. The work of exhalation or exhaling is recovered from potential energy stored in the expanding lung and thorax during inhalation. However, forced inhalation requires additional work by the respiratory muscles. Which muscles are those? Intercostal and diaphragm, diaphragmatic muscles. The actual work of forced expiratory depends on the mechanical properties of the lung and thorax. Mechanical. Work done on an object is the product of work forced exerted on the object times the distance it is moved. Work may be measured in either dyne centimeters or joules as follows. Work equals forced equals distance times distance. I apologize. Pressure equals force per unit distance. Volume is the cube of length, distance, but the product of pressure, P, and volume, V, as the same dimension as work as demonstrated by the following. Now, let me go down a little bit. Work of breathing is calculated by integrating the pressure and volume. Pressure and volume. This is equivalent to determining the area under volume pressure curve of the lung. Change in pressure is plotted in the x-axis. I know it sounds crazy, right, to remember what all these things do and what these are. Now, I'm going to look at the metabolic, the work to perform. The respiratory muscles consume oxygen. The rate of oxygen consumed, or the consumption of oxygen, by the respiratory muscles reflect their energy requirements. It also provides an indirect measurement of work of breathing. So as I keep reading on, the oxygen cost of breathing is assessed by measuring the VO at rest and at an increased level of ventilation. If no other factors increase oxygen consumption, the additional oxygen uptake is a result of respiratory muscle metabolics. The oxygen cost of breathing in a healthy individual ranges from 0.5 to 1 or 1,000 milliliters, or 1,000 milliliters, or 1 liter of oxygen per liter of increased ventilation. This represents less than 5% of the oxygen consumption of the body. At a high level of ventilation, when somebody's breathing very fast, okay, which is higher than approximately 120 liters per minute, liters, not milliliters, the oxygen cost of breathing increases tremendously. Now, when we're looking at oxygen and ventilation, we're looking at oxygen, right? How much oxygen we're pulling into the system, how much the body uses at any given time. Weak muscles take more oxygen to use because they're weak, so they need more help, right? A strong muscle doesn't need as much help, right? When we absorb oxygen, we release CO2. If you have carbon monoxide poisoning, where there's barely any oxygen in your symptoms, in your body, in your system, there's barely any oxygen in your system, how are you feeling? Lightheaded, dizziness, blurry vision, heart rate's up, you got all those factors in there. Does it ever state when you have carbon monoxide poisoning that you're out of breath? No, because the out of breath is caused by what? Your CO2. If what you thought was correct, that oxygen causes out of breath, then that information would be completely contraindicated. It's contradicted completely. It's not the oxygen that causes out of breath. It's the CO2. This is general information. This is something that this is not a thing I make up. I base all the facts off of actual facts, not assumption or theory. So when I'm relaying facts, it's a good idea to take notes, and just kind of, when we take notes, so we can kind of revert back to our notes for that information. It's the best advice I can give you on that. You see, I got a lot of walking in through the day, 3,000, 4,000 steps a day. That's fantastic. Okay, there's a lot of places asking people who have COPD to get paid for clinical trials for a new medication. Is it this legit? It's a good question. It's a very good question, Pamela. I don't know how to answer that besides I do know there are places that do clinical trials and where people can get paid if they have COPD to do these clinical trials. But mind you, they would be deemed as safe, but there could be a lot of adverse reactions. As a college student, when I was in college, I went through some clinical trials to earn some money to pay for my college, because I had 3 jobs and I could probably be able to use a little bit more because I wasn't getting paid a lot. That's why I had 3 jobs, But I had 3 jobs, but I was also doing clinical trials and I was getting paid for those. But it wasn't a lot of money. It was like $20, $40 a week. It wasn't a lot, but it was enough to pay for some food and stuff like that. So I wouldn't expect a lot of money out of it, but I would definitely investigate further, especially the company and who their clinical trials are going through. If they're going through a governmental project, then that is a government agency. Then that might be different, But if it's a big pharma company, that might be different. But it's hard to say, Pamela. It's just, I would definitely investigate further, because I do know there are some out there, and they're legit, but I do know there are some that are not legit. Like, for instance, when they say, we found a cure, and this clinical trial needs you to invest $1,000 or something out of your own money to go through this clinical trial for this cure. There is no cure. If there was a cure, we'll find out right away. We look at these things all the time because we get faxes and information from governmental agencies, so we can relay that information to our clients and patients and healthcare providers. So, Pamela, it's a great question, a very good question, but that is the best answer I could give you is I would investigate further. And that's with anything. I would definitely investigate further. Any other questions? You guys can come up with any other questions you want. We have a couple minutes left, and I usually leave the floor open for anybody who wants to ask questions. I'm looking for something in specific here. Okay. I'm waiting for anybody who wants to write a question up. I'm leaving the floor open for anybody who wants to write up a question. I mean, this book has just a tremendous amount of information, but as it should. All right, if there is no other questions, guys, you can write up any question you want. But if there's no other questions, that's all we have time for today. You need that book? Yeah, it's only about $400. Yeah, these books are not cheap. These are textbooks. That's why I keep mine. But it's 4 years of college to get through a bachelor's, and then you have the other degrees you have to get on top of that. Wasn't really a question, was it, Michelle? Anyways, I think that's all the time we have for today. You guys, any questions you have, just write it up on the comment section. I'll be happy to address those later. But bring up any topics you like. But for our next live, I'm going to be going over some of our patients that are graduated. You're very welcome. I'm going to go over some of the patients that have graduated, what they were able to do versus what they can do now. And I'm actually going to print it out. I just have to find it where it specifically states, because it's so many places, but it's almost like reading a, I think you guys can get this. It's like reading a DVD or a VCR instructions. That's why I was asking about which doctor to see. I'm worried about my heart rate going up too often. Thank you, Alex. Oh, you're very welcome. Yeah, no worries. You can ask me all sorts of questions. but I'm going to give you the right answers, as far as it relates to pulmonary. But I want to make sure we understand that oxygen, it doesn't cause out of breath. This is nothing that, somebody's like this, Alex, my oxygen is dropping, I'm so out of breath. I was like, well, it's probably because you're breathing so shallow. You're only pulling in a little bit of oxygen, was dropping your oxygen down too much, and you're only removing a little bit of CO2 because you only breathe in shallow, so that means you can only breathe out a little bit of CO2. It's not like you're breathing in, a gallon of oxygen and you're releasing a gallon of CO2. You're breathing too shallow for that. So the reason why your oxygen is dropping so much and your work of breathing is climbing is because you're not breathing in deep enough. And when I say that, it's sometimes we just have a hard time understanding it, maybe. But have you tried herbs? It works. I stopped. It's like Nellie Jones is out of the group now. There is no herbs, Nellie. All medications are derived from something natural, but there's no cure, nothing like that. It's pulmonary rehab that fixes the problem, and it's a medical grade with doctors and respiratory therapists and nurses, people that know the ins and outs of pulmonary issues. Yeah, don't, Nellie Jones, whoever that is not a legit person and is definitely not looking out for the best interest of people, because that information is completely falsified and it can actually be hurting people. And of course, that person doesn't want to respond to it. Anyways, guys, that's all the time I have. Thank you very much. I'll see you next time, okay? Why this is not working. Just stop this whole thing, I guess. Sorry, guys, I'm going to have to shut it off on the other side.